Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
But I want to go back to a little bit about the accessibility of actually conducting and completing a case series, because I think that there may be one of the places that, as I was reading through your paper and then also looking back at the surgical, is it the purpose guidelines? Is that right? The
Correct.
purpose guidelines, which are written for case series specifically in surgery, we're looking at practices that are absolutely medicalized and couched within that medical system. And particularly in the United States, massage therapy is very rarely couched within the medical system. Robin is in a situation that is occurring more and more, for sure. But most folks are in practice, and from a case report standpoint, the expectation that there is going to be ethics approval or IRB approval, or even in medicine, for there to be IRB approval to publish a case report isn't a thing. And that's not what the expectations are. And we talk a little bit about this concept of informed consent in the case report guidelines, and what is consent for what? Consent for practice, we have that no matter what, right? We already have that as folks come in, they sign their informed consent, what have you. And what the original care guidelines really beat the drum on was that consent to publish and to be engaged in that work. And while there was a little bit of that patient perspective that was encouraged to be included, we certainly added it from a therapeutic massage standpoint, absolutely. And then, Michael, you really bring that in your case series, which is fantastic. I want to talk a little bit more about that, about how, when you have so many potentially, how that might be done in a practical way, but we'll come back to that. Sometimes gathering all of that information up front isn't something that happens in practice. And when somebody gets the opportunity to look retrospectively, how then does one proceed in being able to get approval for? And so we talk a little bit about that, whether it's, reaching out to them if they're still, around or what have you. Miccio Rosno put together a retrospective case report on a veteran who had undisclosed PTSD, and spoke a little bit about that as well, about how to go, retrospectively get that permission. And so there's that, and there's some pieces in the literature too around differentiating around HIPAA. So I know that is that something that happens outside of the United States? And this is essentially just access to an approval to use medical data and health information. So
we certainly would have a process in place, but it's not that. Yeah.
So, but being able to gather those sorts of pieces in practice, that if a write-up is done well and written to a scientific level that would be appropriate, includes all the components that are needed, and has this due diligence of, okay, here's the consent that was received, that in the States would be acceptable from the standpoint of consent for publication. With the understanding, of course, that it's not identifiable information that's being conveyed, across the board. But when you're looking at those prospective pieces, and particularly, Robin, in that hospital setting, those expectations are going to change a little bit. That absolutely is probably going to be exempt, or at the very least, or the very most expedited review process. But if you are doing something prospectively, all the better to have your bases covered, for sure.
Yeah, look, completely agree with that. I mean, in my own case series, I'm currently running. So we're looking at osteopathic practice and, again, clinical reasoning, neck pain. These practitioners are doing their usual treatment. So, of course, Niki, they have their own intake forms with their own practice consent, ongoing consent, signed consent. But then we had to add another layer of, hey, we're doing a research project. Would you like to participate?
Right.
So we had the participant information sheet with all the facts and information and process, and then, of course, a separate consent form.
And
The reason prospective,
right?
and the reason for adding in the practitioner voice wasn't only to explore well, how was it doing the case series? What did you think? How did you go about your day-to-day practice? But it was actually, tell me about your experience of doing a case series. Did it add an extra burden? Was it difficult? Was the extra paperwork and the extra consent form annoying? Because maybe they're taking on questions they don't understand because they're not the research team. But our reports coming back, and I know you've addressed already, what do we do with that information? Talk about that. But just simply asking our clinicians or practitioners for any burden was an important step for mine, because it then allowed us to then be reflexive and adaptive and go, how can we better support them? Because these practitioners are doing their day-to-day. I have 5 practitioners, 5 clinicians, osteopaths, all with 20 plus years of experience, and we're following them along and asking them to do something different. So that's certainly a layer. Now, to do that, just in Australia, we needed definitely institutional review board, ethics panel committees approval. And even if we were publishing or disseminating or not, because we're accessing patient data and the patient voice and using it prospectively, we needed that consent. And that's coming back just to the previous point I was trying to articulate, that some of our clinics are set up for that. For example, the Royal Melbourne Hospital with the physiotherapy department are set up for that because the physios work in the hospital system. But our massage therapists and osteopaths, as I was saying before, are not set up for that. So some of those allied health professionals and complementary medicine professionals typically have to align themselves to a university, such as an academic like me, who might facilitate the ethics and join the team. But if you're at a hospital, and it sounds like the same in the US, you have your own review committees and your own professionals that you can have going forward. So I think certainly there's systems that will allow for you to navigate the prospective very well, but there's still some systems, as you said, you're piloting, captaining the ship as you're sailing it. They're going to happen, they're going to occur. It's just going to take a little bit of time in other systems and processes. So yeah, definitely it was worthwhile getting the consent, and we also made ourselves available to the patients for any questions and email, video, because we didn't attend the clinics. In fact, I have not set foot in any of the clinics we recruited because we didn't want to go there to then influence and potentially manipulate what was occurring. We just wanted our clinicians doing their day-to-day practice. So hopefully that adds some sort of understanding of the nuance about prospective, but definitely in Australia, we need informed consent.
Now, I'm really curious, would you continue to accept payment for clinical services as normal for these participants enrolled in the case series study?
It's a really, really interesting point, and come back to the fact that prospective studies are hypothesis generating. So a hypothesis that I have already is, would these clients or patients have signed up? So we incentivized them. Okay. We paid for their treatment. Would they have turned up? Would they have participated? Did the payment impact their influence and experience? But if they're paying, maybe they're going to think, okay, well, I won't stick to the certain protocol that we had set out because it's a pain. So, it was sort of this balance, this sort of equipoise argument.
Was paid? Who
my,
are you incentivizing?
My institution.
But who is being incentivized? The patient who's coming and receiving the massage, or the clinicians who
clinician is being reimbursed. So the patient doesn't pay. So if it was $100, that $100 is being paid via us to the clinician. So it's really interesting. It's almost like we know in our world, sorry if I'm assuming something I shouldn't, tell me if I shouldn't, but we know in allied health and physical therapy and massage therapy that if patients could see us for a cheaper rate, they might come more often. Where in most cases, we're not cheap. And that's just because of the health system, particularly in Australia, whereby if someone sees me in practice, it's 110 Australian dollars. And if I need to see them 5 times, it's $500. So with these patients, we thought, well, we might incentivize both the clinician and the patient to continue with the protocol so we can hypothesis generate about that 4-week protocol without money being an issue. So, Robin, it was really difficult. But it was that balance of we want them to more than likely stick to a protocol. And if they had to pay, maybe they wouldn't.
Yep. Makes sense.
So I wanna pull that thread just a little bit more, or a couple of
Please
pieces
do.
that come up in that thread a little bit. And one of the pieces is the recruitment. And how did you access the practices that you recruited to then recruit your participants in this prospective case series?
It took a long time. It took a long time because, again, we're asking these practitioners with 20 years plus experience to engage in something that otherwise wouldn't. And then, of course, they're going to have the question, well, why would I bother? So coming back to your point, Robin, and you, Niki, too, that, our clinicians are wanting to get into research, we really had to sell the story. Participate in clinician-based research, practice-based research, tell us what you do in the real world. So we used social media. We spoke to clinicians we knew. Because again, we're not making then any inference, so there's no, sampling that you shouldn't have done, or, don't just get clinicians that there's not quite the same as an RCT recruitment strategy. So to answer your question, we specifically used purposive sampling, I guess, and targeted those with certain years of experience. We got onto social media, and then once they were interested, I then had a video call with them. And largely just explained the study to them, and got them on board and sort of sold the story. And then how did the clinicians then recruit patients? So we then didn't attend the clinics. We just informed the clinicians about how to go about it, as in, if they identify someone with neck pain, and we looked at non-specific neck pain, how do you identify someone with non-specific neck pain? What is your process? How do you go about it?
Right.
But once you identify someone with non-specific neck pain, please offer them this consent form and this participant information sheet. In other words, they're recruiting for us.
Right.
But first, we really tried to go, we don't want them to desperately go out and just recruit people willy-nilly, because there's no added benefit. They're still getting paid the same amount.
Right.
So whether they saw someone as part of my study or they saw someone off the street, not part of the study, same price. So coming back to the idea of paying them, that's also why we paid them. So yeah, largely the clinicians used their own expertise to diagnose non-specific neck pain. Once they've diagnosed that, they then offered to participate in the study. And largely then all the forms were sent back to the research team. The patient was then engaged, offered a chance to ask questions, and then the clinician or the practitioner was engaged. Is there anything further you need? Once they were happy, they went about the 4-week protocol. So really tricky. It took 18 months to recruit only 5 osteopaths.
I can
Why is that? That's another study in itself.
Right.
Well, what you're describing is like the perfect scenario for a practice-based research network to be engaged and involved, right?
Yes.
And so,
yes.
and I was wondering, Robin is shaking her head, because that's one of the things that, so like MassageNet is a PBRN that the Massage Therapy Foundation supports and cultivating for that very thing, so that there is opportunity for folks to engage, and there's a network of folks that say, yes, we're interested, that's already there and ready.
We have 998 osteopaths out of 3,400 on a practice-based research network.
Yeah, is that Pracky?
That's physiotherapy.
Oh, okay.
We have, but you're close. We have Pracky for physio. We have Acorn for chiropractic.
For the chiro, yes.
Orion for osteopathic. I'm actually one of the people sort of in that committee and in that sort of thing. And that was actually interesting you say that, because we had 998 osteopaths sign up and say, yes, I'll participate in this. We recruited via that, and we had 5. So like per usual, if I'm going about my life and I'm going about my day-to-day practice and I've got my clientele who I'm looking after and doing well, why do I need to do anything further?
Yeah.
So it's really interesting. They may say they're interested in research, and they certainly may be, but when it comes to, can we explore what you do? Maybe it's still another added layer of, I'm not sure.
Well, I tell you, that's one of the things that, so I feel like I'm going, and Robin, if I get too off the rails, man, rein me in, honey.
Take it away.
So we're looking at, we have a MTRIC coming up in 2025, and one of the things that we're doing, and that's the International Massage Therapy Research Conference. And one of the things that we're looking at doing is having the first open session for MassageNet members to come together and talk about sorts of research that they want to conduct. And I'm thinking this case series approach is a perfect mechanism vehicle to do this with the PBRN and with those folks. So this is, I'm really excited about that. And then adding, I want to talk just a hot second about a large case series that was published back in 2015, and this was from Martha Menard, and it was looking at just folks with pain, experiencing pain, and the approach that she did, it ended up being really large. It was published in the Global Advances, and it had like over 100 cases, 100 participants that were in it. And the way that they approached this was that it was a single clinic, single clinician, and it was over the period of so many years, the first visit of somebody who identified with X pain. And that was, and then just going in and taking the records, and it was already the intake and the regular records that were being kept included a visual analog scale on a couple of components across the board. And so that because these documents and things were already set up, and there was a particular protocol that this clinician used, that anytime they had somebody come in, they would give a definition, sort of like you were talking about, Michael. They were given a definition. Okay, this is what this means. They operationalize these different terms and then ask the client pre and post that session to rate their whatever that was. And then, you know, the write-up is put together, and I think it's even open access. So that might be something that we add to this, in addition to your work, add that one just so therapists can overlay that. Because I think those are pieces to talk about for MassageNet. And then maybe we can set up an approach that we can replicate for other things. And we'll send it down your way, Michael. That would be awesome.
Look, yeah, so many opportunities there, and I think what's important is, again, we all know we do good work, but I really agree with your point that not a lot of it's published. You know, we might hear sayings, you might be familiar with phrases or sayings such as, you know, an osteopath is holistic.
Oh no, you froze. I want to know the thing.
An osteopath looks at your whole body.
Start from the top.
Yeah. An osteopath looks at your whole body, or an osteopath is holistic.
Yes.
And I just find those things fascinating, because it's like, how do we know that? That hasn't been written anywhere. No one's told us that we are. So that's part of my fascination of just having, even though we cannot make an inference or draw a causal conclusion with a case series or a case report, it still allows us to generate hypothesis and evolve our practice, rather than, if you're not part of the pyramid and you're not doing RCTs at the top, it's not worthwhile. And that was really one of the narratives when, you know, we were developing the case series guidelines. And I'm sure the other references you've mentioned, Niki, are the same. You know, we can still generate interest and explore interesting nuances in our professions. So I think any opportunity for a practice-based research network like MassageNet, any case series is really useful. And it sounds like in the US, you've got opportunities to align to hospitals and align to ethics panels. And so it sounds really opportunistic.
That's what I appreciate about both of you, actually. I feel like your work really leverages PBRN or otherwise to understand and uncover exactly how clinicians are practicing in the field, because a lot of times that's not readily available.
And that's not what's being done in the RCTs.
Yes.
Which then makes those outcomes less generalizable, even though they're supposed to be the tippity top, right?
Oh, I have a question about that. So, you know, you in this article, you talk about how the case series design it's often the first line of evidence to inform the more rigorous research. So I'm really curious, would it be outlandish to write a case series on an intervention that had evidence from an RCT to really test the external validity or really understand how it's functioning in a real world setting, because a lot of time it doesn't translate. Or is it really just that you do a case series first and then it just goes up the hierarchy?
I think it's useful using a pragmatic lens. Nancy Cartwright in the 90s, who I love, her work, and writing about using a pragmatic lens, looking at the world. So, the biggest issue I see, chatting with colleagues and myself in my own practice, talking to students, is external validity. An RCT shows a change in range of motion of 3 degrees for these patients, and you think, wow. But then you take a bit of a step back and you think, yeah, but would that really translate to my practice? Is that really useful? So,
meaningful.
Is it clinically meaningful? Is it clinically significant? So yeah, I totally get where you're coming from. I think RCTs and findings from RCTs certainly can be explored with a pragmatic lens in clinical practice to really ask that question, so what? How does it impact a clinic? How does it impact day-to-day practice? The only difficulty that we'd have is the narrative that comes out of that, because again, it's just hypothesis generating. So I think it would be fascinating to, for example, follow clinical practice guidelines for sciatica, clinical practice guidelines for managing an ankle, and to actually then go, yeah, but is that what our practitioners are doing in clinical practice? Because I can tell you in Australia, a lot of them are not. GPs, physiotherapists, osteopaths, etc., we're not doing clinical practice guidelines. So I'd love to see, well, why is that? And from a finding from an RCT or clinical practice guidelines, why is that? So hypothesis generating, definitely. And it would really be cool to take a pragmatic lens to that. And I'm absolutely passionate about doing so, because we have a lack of external validity for sure.
But I think of it as, if you think of this pyramid, we see this pyramid, right? It only goes in one direction. And I would actually warrant that you should be thinking about it more like an hourglass, where you've got the pyramid and then the pyramid upside down right on top of it. And I actually think of it three and 4 dimensionally, that it's almost like a tornado coming down the drain, and then something like coming out, the same thing as it goes back into practice. And it's almost, there's an applied theory building image where you see it's circular. It's always going back and refining and refining and refining. And that's what, if we don't take these RCTs and this pieces coming from the meta-analysis and systematic reviews, and even systematic reviews of systematic reviews, right?
That's it,
and then take that information and look at it in practice and see if indeed that is reflective. And so what's it's, right?
Yeah. And it's the post-positivist approach, it's that, the philosophy of science, actually, just because something's shown in an RCT doesn't mean that that thing exists still.
Right.
RCTs are just hypothetico-deductive, A, we think it caused B, but it's all denoted on a, underscored by a p-value, which is probability. So, of course, RCTs, of course, are high-level evidence and useful. But yeah, unless we actually test it or check its validity, as you say, Robin, I think we're remiss. And it's actually remiss of us to not test these things in practice, in my opinion, to see how it actually translates to a patient, which is the whole reason we're doing what we're doing.
Exactly.
So, yeah, I think there's massive opportunities for sure.
I agree. I feel like there's so many other points of conversation. Like, we didn't even get to talk about black box of treatment and how one very specifically, when so much of the work that is done is still individualized, and we meet the person as they show up in that moment, and we can't put a dictated step 1, step 2, step 3. We don't have that. It isn't surgery, right? We're not doing, okay, the first thing, here's where the cut goes, here's where the device is, right? We don't have that.
And this is what we're asking our patients with the patient voice. Your osteopath did these things. Does it matter? And ultimately, our patients have said, no, it doesn't. And they all did things absolutely differently.
I can't wait. I can't wait for that study to come out, Michael, having that little bit of a preview. So here we've highlighted your paper around case series. And we got a sneak peek at some work that you're doing right now that I'm really looking forward to see come out. When is that projected to wrap up, do you think?
Data collection's finishing. I'll use
Okay.
current verbing, finishing. Hopefully the end of the year, manuscript written up and put somewhere. I think there's a really good opportunity in this one to try and have this one more broad. So when I say more broad, we wanted to tell the story or get out the story of the clinician's guide in JBMT for reasons I mentioned earlier. But with this one, we wanted to actually try and get back into the medical field
Sure.
somehow, somewhere, the readership to kind of go, hey, look, there was this study done in osteopathy in Australia, but what we did was we actually positioned the patient and positioned the clinician as well. You should do it too. So yeah, not sure, but hopefully by the end of the year, it's submitted somewhere.
Well, I anticipate that we'll be reaching out again to you to have conversation about that and how it can, because we need to be doing more of this applied and translational scholarship where just because literature is coming out and evidence is coming out in a discipline that is separate but related to us, we need to be pulling in that related work as well. So I look forward to continuing our conversation. It was wonderful to meet you and wonderful opportunity to highlight your work.
Thank you.
And
yeah,
Robin,
this was awesome.
It's great to see you. So I think with that, are there any final parting words that anybody would like to add before we bring ourselves to closure today?
I might add, because this was unscripted, if there's things that I could follow in or fill in or follow up with for your viewership, readership, let me know and I can provide further details or further in, ideas. I'm more than happy to follow up.
Fantastic. Well, and you are the corresponding author on this as well as the first author. Is that correct?
Correct. Yes.
Fantastic. So we'll make sure that your contact details are on this. And
thank you.
Thank you so much for your time today.
Thank you, Michael.
And Robin, for joining us, and all of you out there. Thank you for joining us at Research Perch. The Massage Therapy Foundation puts these together to help inform all of the clinicians out there. So let us know your thoughts. Yeah. So thank you so much, everybody.
Great. Thank you, everyone.
If you enjoyed this podcast, please consider donating to the Massage Therapy Foundation so that we can continue to bring you this and many other resources to increase your knowledge and improve your practice. Thank you.